of the urinary system. The urinary system consists of 2 kidneys, 2 ureters, the bladder, and the urethra. Kidneys and ureters. The kidneys are bean-shaped organs located just under and below the 12th rib near the waist in an area of the body trunk called the flank. They each are surrounded by fibrous capsules and layers of fat. They are tightly wedged between the peritoneum, a membrane that separates them from the digestive system, and a layer of muscle in the back. The halus, or entry, to the kidney is located on the concave surface of the kidney near the spine. The right and left renal arteries branch off from the abdominal artery and enter the kidneys at the halus. The entire blood supply circulates through the kidneys every 4 to 5 minutes. Each renal vein returns filtered blood directly to the inferior vena cava. The kidney is divided into an outer layer, called the cortex, and an inner layer, called the medulla. The cortex receives a large blood supply and is very sensitive to changes in blood pressure, BP, and blood volume. The medulla is organized into 8 to 18 pyramid-shaped structures that concentrate and collect urine and drain it into the calyces. The calyces then drain urine into the renal pelvis. The renal pelvis is at the center of the kidney and forms the funnel-shaped proximal end of the ureter. The ureter carries urine from the renal pelvis to the bladder. The nephron is the functional unit of the kidney. Each kidney has 1 to 1.25 million nephrons. The nephron is a vascular tubular system consisting of a glomerulus, a Bowman capsule, and a tubule. The glomerulus is a mass of blood vessels tucked into the cup-like Bowman capsule. Each tubular system consists of a proximal tubule, the loop of Henle, a distal tubule, and collecting tubules. The nephron is located mostly in the cortex of the kidney, with the loop of Henle dipping into the medulla. A single collecting duct is formed by several tubules and travels through the medulla to the calyces. Bladder and urethra. The bladder is a muscular sac that readily stretches to store urine. The bladder rests on the floor of the pelvic cavity behind the peritoneum. It is located in front of the rectum in men and in front of the vagina and uterus in women. The upper portion of the bladder is called the apex and the base, or fundus, is close to the pelvic floor. The bladder neck, containing the internal sphincter, is the most inferior portion. The trigone is a triangular-shaped area on the posterior wall. The trigone muscles help to close the junction of the ureters and the bladder during urination, preventing backflow of urine into the ureters. Control of the bladder is made possible by sensory and motor nerves. When 200 to 400 milliliters of urine collects in the bladder, sensory nerves cause the urge to urinate. Motor nerves stimulate the detrusor muscles in the base of the bladder to contract and empty. Pelvic floor muscles and external sphincter muscles can be contracted voluntarily to control outflow of urine. Meanwhile, back at the junction of the ureters and the bladder, the trigonal and ureteral muscles involuntarily contract to prevent backflow of urine into the ureters. The urethra is a muscular tube lined with mucous membranes that carries urine from the bladder out of the body. The urethra functions as a sphincter, meaning that it contracts to hold urine in the bladder and relaxes to allow urine to flow from the bladder. Approximately 3 centimeters of the proximal male urethra is encircled by the prostate gland. The urethra is about 20 centimeters long in men and 3 to 5 centimeters long in women. The short length and proximity of the urethra to the female anus are two reasons for the increased incidence of bladder infections in women. Physiology of the urinary system. The functions of the urinary system are regulatory, excretory, and hormonal. Regulatory functions are performed by the formation of urine and the secretion of renin, which affects BP. Regulatory processes maintain fluid balance, keep electrolytes within normal range, and maintain acid-base balance. The excretory function of the kidney is the elimination of urine. The hormonal function is to stimulate red blood cell (RBC) production. Regulation and excretion. Urine production. 3 processes occur in urine production: 1. Glomerular filtration, 2. Tubular reabsorption, and 3. Tubular secretion. Glomerular filtration. Glomerular filtration is an ultrafiltration process in the glomerular capsule. Fluids, electrolytes, and other substances are filtered out of the blood as it passes through the glomerulus. Plasma proteins are too large to pass through the glomerulus and therefore remain in the blood. The ultrafiltration process requires adequate blood volume and BP. The product of glomerular filtration is called the glomerular filtrate. It contains water, electrolytes, i.e., sodium, potassium, calcium, magnesium, chloride, bicarbonate, phosphate, other anions, glucose, urea, creatinine, uric acid, and amino acids. Glomerular filtrate and blood plasma are essentially the same, except that the filtrate does not have proteins. Most of the filtrate is returned to the blood from the tubules by reabsorption. Tubular reabsorption. Water, some electrolytes, and non-electrolytes are reabsorbed from the tubules of the kidney into the blood as needed to maintain normal fluid balance. Reabsorption occurs through diffusion, active transport, and osmosis. Some non-electrolytes, urea, creatinine, uric acid, are not readily reabsorbed and are excreted in the urine. The reabsorption of water reflects the ability of the kidney to concentrate or dilute urine, as necessary. The amount of water reabsorbed is influenced by antidiuretic hormone, ADH, and aldosterone. ADH, stored in the posterior pituitary, affects the amount of water reabsorbed in the distal tubules and the collecting ducts. If blood volume decreases or blood osmolality, concentration, increases, ADH is secreted from the posterior pituitary. The distal tubules and collecting ducts of the kidney become more permeable to water so that reabsorption into the circulating blood increases and urine becomes more concentrated. Tubular secretion. Potassium and hydrogen ions are secreted into the tubules from the blood. This secretion process regulates serum potassium levels and is the basis for the kidney's acid-base regulating mechanism. The normal pH of urine is 4.5 to 8.0. The kidneys and lungs work together to maintain the acid-base balance of the body. The lungs excrete carbon dioxide, CO2, a volatile acid, and the kidneys excrete fixed acids produced by normal metabolism. Base levels are maintained by renal conservation of bicarbonate, excretion of sodium for hydrogen, and excretion of ammonia. The product of glomerular filtration, tubular reabsorption, and tubular excretion is urine. Urine is composed mostly of water, sodium, potassium, chloride, urea, creatinine, and uric acid. The body normally excretes 1 to 2 L of urine each day, which is approximately 1% of the blood filtered by the glomeruli in the same period of time. Glucose and proteins are substances present in blood but not normally present in the urine. Normally, glucose is completely reabsorbed in the tubules. The presence of proteins in urine indicates glomerular damage. Urine is delivered to the renal pelvis, where it flows into the ureter. The production of urine. Urine elimination. Peristaltic waves move urine from the kidney through the ureter to the bladder. The presence of 200 to 250 milliliters of urine in the bladder causes the urge to urinate, although the bladder can distend to hold several times that amount. Urination is a complex process that is under a variety of neural controls and is voluntary for the toilet-trained person with intact motor and sensory nerve pathways. Hormonal stimulation of red blood cell production. Erythropoietin is secreted in the kidneys and stimulates the bone marrow to produce RBCs. This process is triggered by decreased oxygen, in renal blood. Patients in renal failure have a deficiency of erythropoietin, which causes them to become anemic. Age-related changes in the urinary system. Plasma renin and aldosterone levels fall, and tubules are less responsive to ADH as a result of all of these changes. The older person's kidneys are less able to concentrate and dilute urine in response to changes in serum osmolality, concentration. Creatinine clearance decreases with age. This means that the rate at which the kidneys are able to remove creatinine from the blood is diminished. Creatinine clearance is a better indicator of kidney function than serum creatinine. Some decline also occurs in erythropoietin, a factor that may contribute to anemia. In an older person, serum glucose may be considerably elevated before it is detected in the urine. In younger people, urine production peaks during waking hours. This pattern is lost with age such that urine production does not decrease at night. Therefore, older people often have nocturia, meaning that they awaken from sleep to void. The bladder also undergoes changes with age. Bladder muscles weaken and connective tissue increases. The effect is decreased capacity and incomplete emptying. The mechanism that prevents the reflux of urine from the bladder into the ureters is less effective and can contribute to kidney infections. Incontinence is not a normal consequence of age, but it is common. Female urinary incontinence is often caused by relaxed pelvic muscles related to childbirth trauma and lack of estrogen after menopause. In men, urethral obstruction is more often a problem. It is often caused by the enlarged prostate closing in on the urethra. Discuss nursing assessment of the urinary system. Elimination is a very personal activity, and some people are not accustomed to discussing it with others. Therefore, assessment of urinary function and problems may be embarrassing for the patient. Privacy and a calm, accepting manner help to put the patient at ease. Health history. Chief complaint. Patients with urinary problems most often report changes in urine quality or quantity, pain, or changes in urination. History of present illness. Ask about the patient's normal or usual pattern of urination. Important data include volume of urine, frequency of voiding, and appearance of urine. The patient may have difficulty estimating the amount of urine voided, but usually can recognize an increase or decrease from normal. If intake and output records are available, note the recent pattern. Terms used to describe urine volume are polyuria, oliguria, and anuria. Polyuria refers to a large urine output, oliguria to a low output, and anuria to the absence of output. Urine characteristics to record include color, clarity, clear or cloudy, presence of particles, and odor. Hematuria is the presence of blood in the urine. Pain may or may not occur, but it is more common with acute conditions. Painful urination is called dysuria. Inquire about the presence of pain or discomfort. Describe the characteristics of the pain, intensity, location, distribution, onset, duration, frequency, relationship to urination, precipitating factors, and measure that provide relief. Urologic conditions also may cause pain in the flank, abdomen, pelvic area, and genitalia. The pain may be so severe that it causes nausea and vomiting. Include questions about any problem the patient has had with initiating or controlling urination. Document circumstances under which these problems occur. For example, involuntary loss of urine with laughing or sneezing is typical of stress incontinence. Urge incontinence is the inability to hold urine when teeing the urge to void. Past medical history. After the present illness has been fully described, the patient's past medical history should be explored. Significant findings include a history of streptococcal infections, recurrent urinary tract infections, UTIs, renal calculi, stones, diabetes mellitus, gout, or hypercalcemia. Ask if the patient has had urologic surgery, catheterization, examination, example, cystoscopy, radiography, or trauma, and if the patient uses any type of urinary diversion or collection device. Document recent and current medications, including prescription and over-the-counter, OTC, drugs and herbal remedies, because some medications are nephrotoxic, harmful to the kidneys. Note exposure to toxic chemicals in the home or the workplace. Family history. Describe the patient's family medical history. Important conditions to note are congenital kidney problems such as polycystic kidneys or urinary tract malformations, diabetes mellitus, and hypertension. Review of systems. Review the body systems to detect other problems that may be related to the urinary tract complaints. Ask if the patient has had changes in skin color, respiratory distress, edema, fatigue, nausea, vomiting, chills, and fever. Functional assessment. The functional assessment includes information about habits and practices that might affect or contribute to urinary tract disorders. Ask about daily fluid intake because urine production varies with fluid intake. It is also helpful to determine the patient's usual exercise pattern because excessive exercise or prolonged immobility affects the urinary system. Determine the effects of the chief complaint on daily life as well. Physical examination. The physical examination begins with inspection of the skin for color, i.e., ashen, yellow, and the presence of crystals on the skin, i.e., uremic frost. Evaluate tissue turgor to detect dehydration or edema. Examine the area around the eyes for periorbital edema, which suggests fluid retention. Inspect the mouth for moisture and odor. Patients in renal failure may have an odor of urine on their breath. Observe respiratory rate, pattern, and effort. Respirations may be rapid with metabolic acidosis, infection, and fluid overload. Kussmaul respirations, seen with metabolic acidosis, are rapid and deep. Dyspnea may be evident with fluid overload. Auscultate the lungs for crackles or rhonchi that may indicate fluid overload. Heart rhythm irregularities may be noted with potassium imbalances. Inspect the abdomen for scars and contours and palpate for tenderness and bladder distension. Auscultate the kidney area over the costovertebral angle to detect renal bruits, swishing sounds caused by turbulent blood flow. Renal bruits indicate renal artery stenosis, narrowing. Then percuss the abdomen. A dull sound may be heard over a full bladder. Pain may be elicited over one or both kidneys. Observe for edema throughout the examination. With renal failure, edema is generalized, not dependent. The skin may be dry, flushed, and shiny over the edematous area. The last part of the physical examination is inspection of the genitalia. Standard precautions should be observed. Examine the penis for lesions, scars, or discharge. If there are penile lesions or urethral discharge, smears should be obtained for culture. A nurse with advanced skills or the physician also may perform rectal and pelvic examinations, especially if symptoms suggest problems of the reproductive system. The pelvic examination may reveal gynecologic rather than urologic problems. The male rectal examination helps to detect prostate enlargement, which often creates problems with voiding. Discuss diagnostic procedures and test. Diagnostic procedures and test. Urine tests. Urinalysis. A urine specimen is examined for color, pH, specific gravity, glucose, protein, blood, ketones, and bilirubin. Normal urine is straw-colored and slightly acidic. Microscopic examination is used to assess for cells, casts, bacteria, and crystals. Chemical examination to assess electrolytes and osmolality, concentration, of the urine determines the ability of the kidneys to excrete or conserve electrolytes and water. By comparing the osmolality of urine with serum osmolality, it is possible to know if the kidneys are functioning appropriately. If serum osmolality is elevated, the kidneys should reabsorb or conserve water to dilute the serum and excrete more concentrated urine, i.e., urine with high osmolality. If serum osmolality is low, urine is dilute, the kidneys should reduce reabsorption of water to increase serum concentration and produce more dilute urine, i.e., urine with low osmolality. Specific gravity is a measure of osmolality. Urine culture and sensitivity. Normal urine is sterile. A urine culture permits identification of microorganisms present in the urine. Sensitivity testing determines which antibiotics will be effective against the specific organisms. The specimen can be obtained by the patient, if able, or the nurse. If an antibiotic is ordered, collect the urine specimen before starting the antibiotic drug. Creatinine clearance. Creatinine clearance, the rate at which the kidney removes creatinine from the blood, is the best test of overall kidney function. It serves as an estimate of glomerular filtration rate. This test requires collection of all urine for 12 or 24 hours, as ordered. Normal levels vary for men and women. Because values depend on muscle mass, they are usually lower in women. Urine and serum creatinine levels are compared to urine and serum creatinine levels are compared to determine kidney function. If serum creatinine rises and urine creatinine falls, it is an indication of decreased kidney function and glomerular filtration rate. Blood tests. Blood urea nitrogen. The blood urea nitrogen, BUN, test is a general indicator of the kidney's ability to excrete urea, an end product of protein metabolism. In addition to renal failure, factors that increase BUN are a high-protein diet, especially with renal disease, gastrointestinal, GI, bleeding, dehydration, and some drugs, aspirin, chemotherapeutic drugs, diuretics, gentamicin, lithium carbonate, morphine, corticosteroids, sulfonamides, tobramycin. Serum creatinine. Creatinine is a waste product of skeletal muscle breakdown. The level of creatinine in the blood is an indication of the kidney's ability to excrete wastes. Serum creatinine is elevated only in renal disorders and is a better measurement of kidney function than BUN. Unlike BUN, creatinine is not influenced by diet, hydration, nutritional status, or liver function. With normally functioning kidneys, the serum creatinine level is very low and the urine level is high. The normal ratio of BUN to creatinine is 12 to 1 to 20 to 1. Serum electrolytes. Serum electrolytes must be monitored in a renal patient because imbalances can have very serious consequences. In renal failure, sodium and potassium levels are elevated and calcium levels are decreased. Radiographic tests and procedures. Kidneys, ureters, and bladder. A KUB, for kidneys, ureters, and bladder, is a radiograph that provides a general outline of the kidneys, revealing their approximate size and contour. Tumors, malformations, and calculi may be found with this type of radiograph. This procedure requires no special preparation or aftercare. It is not done on pregnant patients, and it should be done before any other studies that require contrast media. Intravenous pyelogram. An intravenous pyelogram (IVP) is a diagnostic procedure in which a radiographic contrast medium, dye, is injected intravenously. Radiographs of the KUB are taken at 5 to 15-minute intervals. As the contrast is concentrated by the kidneys and excreted through the ureters into the bladder, kidney function and structures, ureter size and patency, bladder size and shape, and presence of calculi, stones, or other obstructions can be assessed. The procedure is contraindicated in older adult patients with known renal insufficiency and in patients with diabetes mellitus or multiple myeloma. Renal arteriogram. A renal arteriogram permits study of the renal blood vessels. It is used to diagnose renal artery stenosis, aneurysms, vascular tumors, renal cysts, and renal infarctions. A catheter is inserted through the femoral artery and threaded into the aorta. A contrast medium is injected into each renal artery and radiographs are taken as the contrast passes through the kidneys. Cystogram. Contrast media can be instilled in the bladder using a catheter or a cystoscope. Films are then taken to visualize the bladder. This procedure is useful in detecting reflux of urine from the bladder into the ureters. Renal scan. A renal scan indicates the size, shape, and location of the kidneys, detects renal infarction, atherosclerosis, trauma, or rejection of a transplant, and identifies primary renal disease. An intravenous radioisotope is injected and radiographs are taken to demonstrate blood flow to each kidney. The test is not done on pregnant women but can be used for patients who are allergic to contrast that contains iodine. Computed tomography and magnetic. Resonance imaging. A computed tomography (CT) scan is useful in detecting kidney size, tumors, abscesses, obstruction, and adrenal masses and tumors. Contrast media may be used to clarify details, assess the patient for iodine sensitivity. Magnetic resonance imaging (MRI) also may be used to visualize the kidneys. Renal ultrasound. Ultrasonography, ultrasound, uses high-frequency sound waves to create images of the bladder. It is used to detect urinary tract malformations and obstructions, tumors, renal calculi, perineal fluid accumulation, and cysts. Ultrasound also may be used to guide a needle inserted to aspirate specimens from cysts or tumors. The bladder should be full for visualization of organs and tissues. The procedure may be done through the abdominal wall, transabdominal, the rectum, transrectal, the urethra, transurethral, or the vagina, transvaginal. Preparation and patient instructions are specific for each approach. Invasive procedures. Renal biopsy. A renal biopsy is performed to obtain a specimen of renal tissue for direct microscopic examination. It is usually done to evaluate conditions leading to renal failure. The procedure may be done through open or closed methods. The open method is a surgical procedure in which an incision is made in the flank and a specimen of kidney tissue is removed. The closed procedure involves insertion of a needle under fluoroscopy or ultrasonography to aspirate the tissue specimen. For the closed procedure, the patient must be able to lie in the prone position with a blanket roll under the lower abdomen for up to 45 minutes. Patients with breathing problems may not be able to tolerate this position or alter their breathing patterns as needed during the procedure. The most serious complication of a renal biopsy is hemorrhage. If bleeding is suspected, the patient is given intravenous fluids to restore fluid volume. Persistent bleeding may require surgery. Cystoscopy. Cystoscopy is the direct visualization of the interior of the urethra, bladder, and ureteral orifices. The procedure may be done in the physician's office for diagnostic reasons or in an outpatient facility for diagnostic or treatment purposes under local or general anesthesia. As a diagnostic procedure, the cystoscopy allows the physician to observe lesions, locate sources of bleeding, and take biopsy samples. Treatments that can be performed with this procedure include cauterization of lesions, removal of calculi, tumors, or foreign materials, implantation of radium seeds, insertion of ureteral catheters, and control of bleeding. A lighted tube, called a cystoscope, is inserted through the urethra into the bladder under sterile conditions. Retrograde pyelography, which involves injecting contrast into the ureters, also can be done during cystoscopy. Back pain, bladder spasms, urinary frequency, and burning on urination are common after cystoscopy. Mild analgesics may bring relief. Belladonna and opium suppositories may be ordered to reduce bladder spasms. Bladder perforation is rare but should be suspected if the patient has severe abdominal pain. Urodynamic studies. Urodynamic studies are performed to determine the physiology of urination. The studies assess innervation of the bladder, incontinence, and other variations in urinary patterns. Urodynamic studies measure the rate and volume of urine flow during voiding. The rate of flow is decreased with obstruction or decreased innervation. Cystogram and voiding cystourethrogram. The cystogram outlines the contour of the bladder and shows reflux or backflow of urine from the bladder into the ureters. Cystograms are useful in diagnosing neurogenic bladders, fistulas, tumors, and ruptured bladders. For a cystogram, a catheter is inserted into the bladder, contrast is injected, and then radiographs are taken. A voiding cystourethrogram gives the physician additional information on urethral disorders during voiding. The bladder is filled with contrast and radiographs are taken during and after urination. This procedure may be embarrassing for the patient. Explain the need for the test and provide as much privacy as possible during the procedure. Cystometrogram. The cystometrogram is used to evaluate bladder tone in the patient with incontinence or with a neurogenic bladder. A catheter is inserted in the bladder and fluid is instilled until the patient reports the urge to void. When the patient feels urgency, the catheter is removed, the patient voids, and residual urine is measured. Drugs may be given to see if they effectively enhance or relax bladder tone in the individual patient. Discuss common therapeutic measures. Catheterizations. Catheterization is the introduction of a catheter through the urethra into the bladder for the purpose of draining urine. Catheters are inserted when patients are unable to void because of the effects of anesthesia, paralysis, trauma, unconsciousness, certain surgical procedures, and other factors that inhibit voiding. The major concern with catheterization is the potential for introduction of bacteria in the normally sterile bladder. Catheterization is the primary cause of healthcare-associated infections, HAILs. Therefore, it is essential that strict aseptic techniques be followed when catheterization is necessary. Urinary catheters are available in a variety of sizes for adults. The most used sizes for adult urethral catheterization range from the small 12 French to the larger 18 French. Catheters may be of a retaining or non-retaining design. Examples of retaining catheters are the Coude, Foley, Malacot, and Pezer. A retaining catheter is one that has a device, such as an inflatable balloon, that anchors the catheter in the bladder. Robinson and Whistletip catheters are non-retailing or straight catheters. Nurses are most familiar with Foley catheters that have either double or triple lumina. Malacot and Pezer catheters are used most often as suprapubic catheters. To determine whether a patient is emptying his or her bladder, the amount of urine remaining in the bladder after voiding, residual urine, must be measured. A bladder scanner can be used to measure post-void residual, PVR. This procedure may be diagnostic, but it is often part of a bladder training program for patients who have lost control over bladder function. Residual volume should be measured immediately after voiding. Occasionally, patients are catheterized to measure residual urine. Less than 50 milliliters of residual urine is considered normal. Key points to remember when catheterization is necessary are the following. 1. Catheterize only after other non-invasive measures have failed or when necessary. For diagnostic purposes. If possible, have the patient shower or bathe before catheterization. 2. Wash hands thoroughly and use sterile techniques and equipment to insert the catheter. 3. With an indwelling catheter, do the following. I. Secure the tubing to the female patient's inner thigh or the male patient's upper thigh or lower abdomen. B. Handle the catheter gently to avoid trauma to the urethra. C. Keep the urine collection bag below the level of the patient's bladder and the tubing in a circular fashion on the bed. D. Keep the drainage system closed as much as possible. E. Empty the bag before it is full. A full bag inhibits urine drainage, which could cause bladder spasms. F. Provide perineal care twice. Note, antibiotic ointments are daily. Not recommended. Ureteral catheter. A ureteral catheter intreated through a ureter into fine renal pelvis. A ureteral catheter permits urine to flow through the swollen ureter after traumatic surgery. The catheters connected to a drainage system and output is measured every 1 to 2 hours. Record output from this catheter separately from other urine output. The capacity of the renal pelvis is only 3 to 5 milliliters. If irrigation is ordered, slowly instill no more than 5 milliliters, or less, as ordered, of lukewarm, sterile normal saline. Use strict aseptic techniques for irrigation. Unless both ureters are completely obstructed, urine continues to drain into the bladder. Remember to record urine from each source on the output record. The patient with a ureterostomy tube is usually kept on bed rest unless a double catheter is used. The double catheter has one coiled end in the renal pelvis and the other coiled end in the bladder. Nephrostomy tube, some urine usually leaks around the tube and flows through the flank incision. Perform sterile dressing changes and skin care as needed. Irrigation with a small amount of sterile normal saline may be ordered. Because of the small capacity of the renal pelvis, no more than 5 milliliters of irrigating fluid is used. You must use strict aseptic technique. Urinary stent. A stent is a hollow tube that is placed in a structure to give it support and allow fluid to flow through. A urinary stent may be placed in the ureter to maintain alignment or to provide a route for urine drainage. The physician inserts the stent. It may be completely internal, or it may extend through the urethra or skin. Several types of stents are available. Urologic surgery. Urologic surgery may be done on any part of the urinary tract. Nephrectomy is removal of the kidney because of cancer, massive trauma or bleeding, severe chronic failure with infection, or polycystic kidney disease, or for donation. Many types of surgery are used to remove calculi, depending on their location. Preoperative care. Preparation for urologic surgery includes a complete diagnostic workup to rule out other medical problems. Fluid status is evaluated, and any imbalances are corrected. Bowel cleansing may be ordered before some procedures. If the patient has a stoma for urine drainage, an enterostomal therapist is usually consulted to identify the optimal stoma site as well as for patient counseling and teaching. Postoperative care. After surgery, particular attention is given to urine output, respirations, and bowel function. Output is closely monitored, with drainage from various tubes recorded separately. Urine output of less than 30 milliliters should be reported to the physician. Flank or abdominal incisions cause pain and deep breathing. Adequate pain management and support of the patient for coughing and deep breathing decrease the risk of atelectasis and pneumonia. Auscultate lungs frequently to assess breath sounds. Urologic surgery often involves manipulation of the bowel, which can lead to paralytic ileus. Therefore, food and fluids are usually withheld until bowel sounds are present. Drug therapy. Several drugs are available to treat urinary tract disorders. Major classifications of commonly used drugs are diuretics, antihypertensives, phosphate binders, hormones, vitamin and mineral supplements, and immunosuppressants. Complementary and alternative therapies, herbal remedies, like medications, can be harmful to the kidney. For example, aloe can cause nephritis and ephedra, ma huang, can cause kidney stones. Teach patients to include alternative remedies in their medication histories. Discuss Table 42, 3 medications for urinary disorders. Drug use and action. Side effects. Nursing interventions. Diuretics, general information. Specific classes follow. Causes kidneys to excrete water and sodium and lower blood pressure. Dehydration, electrolyte imbalances. Monitor the patient's intake and output, blood pressure, and weight. Administer the drug in the morning to avoid nocturia. Assess for electrolyte imbalances. Monitor serum potassium level. Potassium supplements may be ordered except with potassium-sparing drugs. Osmotic diuretics, mannitol. Edema, dehydration, electrolyte imbalances. Monitor for circulatory overload and excavation during infusion. Administer only freshly prepared solutions. Thiazide diuretics, hydrochlorothiazide, hydrodiurol. Hypokalemia, hypercalcemia, hypertension, hyponatremia. Monitor for patients with diabetes for hyperglycemia. Monitor patients taking digoxin for low potassium levels. Encourage potassium-rich foods. High ceiling, loop diuretics, furosemide, Lasix. Orthostatic hypotension, hypokalemia, hyponatremia, hearing loss. Monitor patients with diabetes for hyperglycemia. Encourage potassium-rich foods. Teach patients to cope with orthostatic hypotension. Potassium-sparing diuretics, spirolactone, aldactone, triamterene, direnium, amiloride, midamor. Hyperkalemia, drowsiness, gynecomastia in men on long-term therapy, menstrual irregularities, impotence. Safety measures. Assess for hyperkalemia, diarrhea, muscle twitching, and dysrhythmias. Caution with angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, and direct renin inhibitors. Antihypertensive agents, general information. See specific classes below. Lower blood pressure. Orthostatic hypotension. Reflex tachycardia and fluid retention with some types. Rebound hypertension if stopped suddenly. Monitor the patient's BP. Do not discontinue the drug suddenly. For orthostatic hypotension, teach patients how to change position slowly and avoid prolonged standing. Centrally acting alpha-2 agonists, methyldopa, aldamate, clonide, catapress. Reduce sympathetic stimulation. Drowsiness, hemolytic anemia, liver damage. Sedation, administer the drug at bedtime. Dry mouth. Take safety precautions. Advise the patient to discontinue the drug only under medical direction. Alpha-adrenergic antagonists, prazosin, minipress. Increase kidney perfusion, block sympathetic stimulation of blood vessels, permitting vasodilation. Orthostatic hypotension, especially with initial dose. Give the first dose or increased dose at bedtime. Teach the patient to manage orthostatic hypertension. Beta-adrenergic blockers/antagonists, propranolol, indirol. Inhibit the renin-angiotensin-aldosterone system. Bronchoconstriction, bradycardia, hypoglycemia, heart failure. Mass symptoms of low blood glucose. Monitor respirations in asthmatics and patients with chronic obstructive pulmonary disease. Assess for edema. Monitor glucose levels. Direct-acting vasodilators, hydralazine, aprezoline. Relaxation of blood vessels lowers peripheral resistance. Tachycardia, palpitations, headache, lupus-like syndrome. Report lupus-like signs, fever, sore throat, skin rash. Phosphate binder. Aluminum hydroxide gel, amphogel. Binds with phosphate in the intestines to prevent absorption. Given to prevent renal osteodystrophy. Raises serum calcium. Hypophosphatemia, muscle weakness, anorexia, bone pain, constipation. Monitor the patient for hypophosphatemia. Record bowel movements. Give laxatives and stool softeners as ordered. Vitamin and mineral supplements. Ferrous sulfate. Treats iron deficiency anemia. Constipation or diarrhea, dark stools. Administer the drug on an empty stomach with water. Can give the liquid with water or fruit juice to disguise taste. Folic acid, calcium gluconate. Supplements dietary intake. Treats hypocalcemia. Although few adverse effects are produced by these medications, occasional side effects include hypercalcemia and constipation. Monitor the patient for occasional hypersensitivity. Monitor blood studies. Administer the drug in divided doses with or after meals. Do not give the medication with other drugs. Erythropoietin. Improve red blood cell formation. Reverse anemia. Require adequate serum iron and ferritin to be effective.
Hedase, tachycardia, hypertension, dyspnea, diarrhea, hyperkalemia, nausea, vomiting, clouded vascular access, seizures.
Monitor the patient's blood pressure. Contraindicated in uncontrolled hypertension. Dosage is adjusted to maintain hemoglobin between 10 and 11 grams per deciliter. Antibiotics. Sulfonamides. Sulfasoxazole, gantracin. In combination with trimethoprim. Treat urinary tract infections. Drowsiness, dizziness, agranulocytosis, anemia, thrombocytopenia. Nausea, vomiting, diarrhea. Liver dysfunction. Crystal urea leading to renal tubular damage. Photosensitivity. Allergy. Infertility. Tell the patient that his or her urine will be orange. Monitor blood cell counts. Give the drug with a full glass of water. Maintain urine output of 1,500 milliliters per day to prevent crystal urea. Have the patient avoid excessive sun exposure. Do not give the drug if the patient has a history of sulfonamide allergy. Trimethoprim, Trimpex. In combination with sulfamethoxazole. Used to treat acute or chronic UTIs. Especially effective against recurrent UTIs in men. Nausea, vomiting, glossitis. Skin rash. Tell the patient to report any skin rash, which may be an allergic response. Aminoglycosides, gentamicin, garamicin. Effective against gram-negative bacilli. Ototoxicity, hepatotoxicity, nephrotoxicity, neurotoxicity. Assess the patient hearing. Drugs should be stopped if patient has tinnitus or subjective hearing loss. Monitor intake and output. Check blood urea nitrogen and creatinine. Penicillins, ampicillin. Effective against most gram-positive and some gram-negative pathogens. Anaphylaxis, GI distress, rash, blood dyscrasias. Monitor the patient for allergic reaction, rash, itching, wheezing. Report any evidence of an allergic reaction to the physician immediately. Fluoroquinolones, ciprofloxacin. A broad-spectrum antibiotic that is effective against many gram-positive and gram-negative pathogens. Drowsiness, headache, agitation, seizures, cardiac dysrhythmias, hepatotoxicity, pseudomembranous colitis. anaphylaxis, severe skin reactions, crystalluria. Observe the patient closely for an allergic reaction, rash, pruritus, gear to carrier, wheezing. Notify the physician immediately if one occurs. Monitor the patient's liver function test period. Advise the patient to drink 1,500 to 2,000 milliliters of fluid each day to prevent crystal formation. Do not give the drug within 2 hours of antacids, iron, or zinc. Check for many other drug-drug interactions. Use safety measures for drowsiness. Urinary antiseptics. Methanamine, mandelamine. An antibacterial agent that is effective only in chronic lower urinary tract infections. Nausea, vomiting, diarrhea. Give the drug with Muse to reduce GI effects. Encourage adequate fluids. Discourage large intake of milk products. Do not use in combination with sulfonamides. Nitrofurantoin, furidantin, macrodantin. Treats acute and chronic UTIs. Dyspnea, nausea, vomiting. Numbness and tingling of legs. Hematologic reactions. Headache, vertigo, drowsiness. Administer with food or milk to reduce gastric distress. Fosfomycin, Monurol. Treats uncomplicated UTI. Diarrhea, headache, vaginitis, nausea. Single-dose regimen, 3 grams water-soluble packet. Discuss urethritis and nursing care. Include risk factors for UTI. An inflammation of the urethra may be caused by microorganisms, trauma, or hypersensitivity to chemicals in products such as vaginal deodorants, spermicidal jellies, or bubble bath detergents. Most frequently identified causative microorganisms are E. coli, chlamydia, trichomas, Neisseria gonorrhea, and herpes simplex virus type 2. SNS include dysuria, frequency, urgency, and bladder spasms. Urethral discharge may be noted. Diagnosed based on patient sign and symptoms, urinalysis, and urethral smear. Cystitis may be present at the same time. Risk factors. Foreign bodies, urinary stone, catheters. Compromised immunity. Female gender. Vaginal infections. Bubble baths and vaginal deodorant sprays. Dehydration. Tight fitting, synthetic undergarments. Infrequent voiding. First trimester of pregnancy. Trauma during delivery. Medical treatment. Antimicrobials are used to treat the condition when it is caused by microorganisms. If the patient is sexually active, the patient and the sexual partner may be treated with antimicrobials to prevent reinfection. Nursing diagnosis and goals and outcomes criteria. Acute pain related to tissue inflammation. Goal is pain relief. Patient states pain is relieved, relaxed manner. Ineffective self-health management related to lack of knowledge of CARS, treatment, and prevention of urethritis. Goal is patient manages treatment plan effectively. Patient accurately describes treatment and describes treatment of and preventative measures, has no recurrence. Interventions. Sitz baths are soothing and may reduce the pain of urethritis. Instruct female patients to wipe from front to back after toileting and to avoid before and after sexual intercourse as means of preventing urethritis. Goals and outcomes. Discourage bubble baths and vaginal deodorant sprays. Instruct uncircumcised male patients to clean the penis under the foreskin regularly. Advise patients to void after swimming. Discuss cystitis, nursing care, and patient teaching. Cystitis is the inflammation of the urinary bladder. It is most caused by bacterial infection. Prolonged immobility, renal calculi, urinary diversion, indwelling catheters, radiation therapy, and some chemotherapy. Women are more susceptible to cystitis than men are. This due to the fact that their urethra is shorter and closer to the vagina and rectum. The longer urethra and antibacterial substances in prostatic fluid are thought to decrease the incidence of UTIs in men. Cystitis in absence of other urinary tract issues is referred to as uncomplicated. Recurring UTIs are usually associated with other urinary tract pathology. Signs and symptoms: urgency, frequency, dysuria, hematuria, nocturia, bladder spasms, incontinence, and low-grade fever are all symptoms of cystitis. Urine may be dark, tea-colored, or cloudy. Fever, fatigue, and pelvic or abdominal discomfort are common. Bladder spasms may be manifested by pain behind the symphysis pubis. Spasms may occur during or after urination. Some patients have bacteria in the urine but no symptoms at all, a situation that does not warrant the use of antibiotics. Medical diagnosis: a urine specimen is obtained for urinalysis, culture, and sensitivity. The presence of bacteria does not mean that the patient has an infection unless the patient also has white blood cells, WBCs, in the urine. The presence of white blood cells reflects bacterial tissue invasion, which indicates infection. Other diagnostic tests may be used to rule out pathology that might have caused the infection. Medical treatment: cystitis is treated with antibiotics that concentrate in the urine. The physician may order an antibiotic while awaiting the results of the culture and sensitivity. The order is changed if the results show that another antibiotic would be more effective. For uncomplicated cystitis, treatment may be given in a single dose or in a 1 to 3 day regimen. Patients with recurrent cystitis may be placed on continuous prophylactic antibiotics. A mild analgesic, such as acetaminophen, is useful for relieving discomfort. Phenazopyridine may be ordered for 2 to 3 days to decrease discomfort and bladder spasms. Hyoscyamine, Cystaspas, and flavoxate, Urispas, also may be ordered to decrease bladder spasms. Nursing assessment: assessment of patients with cystitis focus on patient symptoms, possible causes, and understanding of treatment and prevention. Nursing diagnoses: acute pain related to infection. Pain relief is the main goal for this diagnosis. Infective self-health management related to lack of knowledge of cause, treatment, and prevention of cystitis. Effective management is the goal here. Interventions, usually treated on an outpatient basis. Advise the patient to take analgesics as ordered. Warm sitz baths may prove comforting. Patient teaching emphasizes the need for high fluid intake, instruction about prescribed drugs, and measures to avoid future infections. The patient needs to consume at least 30 milliliters per kilogram of fluid per day and void frequently. Fluid should be consumed during the day and night so that urinary tract is continually flushed. Instruct the patient to complete the entire course of prescribed antibiotics. Also advise the patient taking phenazopyridine, a drug that relieves burning on urination, that the drug causes orange red urine capable of staining clothing. Patient teaching: to reduce the risk of future infections, patients should I wear cotton undergarments to keep the perineum drier than synthetic materials. Moisture encourages bacterial growth. Avoid tight-fitting clothing in the perineal area. Take showers instead of tub baths. Avoid coffee, tea, carbonated beverages with caffeine, and apple, grapefruit, orange, and tomato juices, because these irritate the bladder. Cranberry juice is sometimes recommended to acidify urine and discourage bacterial growth. There is disagreement about its use, but it is a safe, simple measure to try. Women should wipe front to back after bowel movements or voiding. Drink a glass of water before swimming and before and after intercourse to flush the urethra. Keep appointments for follow-up urinalyses to ensure the infection has been eliminated. Instruct patients to complete the entire course of antimicrobial therapy to ensure that the infection is eradicated. Discuss interstitial cystitis, nursing care, and patient teaching.